Health at the University of Washington, lead author of our report. Alison Cox, Policy and Advocacy Director at the NCD Alliance, and Napal Alvani, who's a member of the Our Views, Our Voices Global Advisory Committee and founder of Diabetes Blue Circle India. So if you also, just to be clear, before we get started with our panelists, if you have questions for any of our panelists, please indicate and add your question to the chat facility that hopefully you can see. Please make clear your name, your media outlet, and who you're directing your question to. And at the end, we'll get through as many questions as we can. And please try and keep your question as brief as possible as well. So with no further ado, let me hand over to our first speaker. Very pleased to introduce Dr. David Watkins, Associate Professor of Global Health at the University of Washington, lead author of the report, Delivering on Health and Financial Protection for All. Over to you, David. Thank you.
Thanks very much, Katie, and thanks for the opportunity to speak here this afternoon. This report was put together in recognition of a growing problem, which is that non-communicable diseases, which we take to include mental health conditions and neurological disorders, are growing very fast all around the world. A lot of this is driven by populations getting larger and getting older, but we expect the number of individuals needing care for these conditions to increase by about 50% over the next 25 years. And that's going to put a lot of pressure on public healthcare systems to deliver more services to more people. And the problem is that many countries are massively underspending on these services compared to what is needed. I say underspending, but actually countries are spending. They're just spending on things that are not very cost effective. There's a lot of emphasis on expensive treatments, pressure from pharmaceutical industry to do more, adopt new drugs. And so spending is not being directed towards high value care in many countries. Now, the UN General Assembly resolution that was discussed a minute ago calls upon countries to commit greater resources to responding to NCDs, and this report attempts to quantify how much money that would be. So what we did was to look at a benchmark for spending on a core set of services based mostly in primary healthcare settings, with an emphasis on prevention and early treatment. So treating high blood pressure and diabetes, responding to episodes of depression and psychosis, giving pill-based secondary prevention or prevention after an event for people who have heart disease, things like that. And when we looked at the cost of these services at reasonable levels of population coverage, meaning people can access services when they need them, and at very low out-of-pocket costs, importantly, we found that would require governments to spend somewhere on the order of 1% to 2% of national incomes on these services. Now, a lot of that spending is on medicines, because medicines are a large part of what is part of the response for these conditions. So insulin for diabetes, inhalers for asthma, things like that. So we looked at actually what the range of spending on medicines is in various countries and found that there's a large variation, oftentimes not really predicted by income. And it turns out that sometimes the lowest resource countries pay the most for medicines. So we looked at what would happen if countries actually achieve competitive prices, were able to procure those essential medicines at competitive prices. And you could see the amount of money that needed to be spent would be somewhere less than 1%, maybe 0.8, 0.9% of GDP. So you could achieve substantial efficiency in spending by getting drug prices down. But overall, we infer that if a benchmark for spending on health in many countries is around 5% of GDP, this would be maybe 15 or 20% of the health system budget focused on NCDs. And this is an amount of money that is reasonable and sustainable by most standards, but is much more than many countries are spending, because many countries are being pressured to not spend on health. In fact, health is being deprioritized in many countries after the pandemic. And so what we call for is a reallocation of resources towards health, and specifically towards preventing these very costly and damaging conditions in the coming decades when we expect them to increase. How will we achieve this? Our message is focus. A lot of the conversation on NCDs is not prioritizing very essential cost-effective services in primary care. We say focus on the basics, focus on doing things that ensure access to everybody, Be aware of the pressure to increase spending on new and costly drugs. Focus on getting cheap generic medicines out to many, many people to prevent complications and further spending down the road. Focus also on reducing prices because, as I mentioned earlier, prices are way too high in many countries and they're purchasing at not very high volumes and they're paying way too much as a result. So if you can trade out volume for profit or volume for price and achieve lower prices and procure similar volumes, you can treat more people. We also know from many countries' experience that when governments work together, when groups of countries and states and provinces within countries work together to procure medicines, we can get those medicines a lot cheaper. So collective action and working together is a key part of this. And importantly, we have to focus on the worst off because it is unfortunately true that access to care for NCDs is preferentially these days towards those who are urban, who are fairly well off. And by investing in primary health care and investing in supply chain strengthening for medicines, investing in infrastructure in rural and underserved areas, this is really the way to deliver on the commitment to universal health coverage in particular, and for NCDs specifically. Thanks very much.
Thanks very much, David. Now I'd like to turn to the NCD Alliance's Policy and Advocacy Director, Alison Cox, who'll be able to provide a little bit more about the findings of this report in the context of the UN high-level meeting on NCDs and mental health, the political declaration that I mentioned at the beginning, and the broader global NCD policy response. Over to you, Alison.
Thanks, Katie, and thanks, David. And thank you to all the journalists who are joining us today, because this is, as Katie said, a very important moment just ahead of the 4th UN high-level meeting, when the negotiated political declaration has been finalised and just before it gets agreed at the high-level meeting. So I'm going to focus on the NCD Alliance's takeaways, our headlines about that declaration, what governments are committing to. And of course, it's been a challenging process in a very challenging time for global health. So the first thing to say is we're very pleased that we've got to this point. We do have a declaration that the government, the President of the General Assembly feels confident in taking forward. But coming into this, we at the NCD Alliance really recognise that since the first high-level meeting on NCDs back in 2011, there's been a great deal of progress in terms of global policy development and adoption, action plans, tools that have been developed, but there's been a significant implementation gap. And that was really reflected in the UN Secretary-General's progress report to the General Assembly on progress on NCDs since the last high-level meeting in 2018. And that found only 19 countries are on track to meet the Sustainable Development Goal, SDG 3.4, of a 1/3 reduction in NCD mortality by 2030, just 19. So with that context, our main message going into this whole process is that we've been calling for leadership and for commitment to accelerate action on NCDs. So we are warmly welcoming the time-bound and tangible targets that are set in this political declaration. And their agreement through this whole negotiation process shows real political acknowledgement by the government of the need to accelerate progress. Like I say, the previous 3 declarations have stopped short of including this kind of specific measure. And particularly I would flag up front the 3 fast-track targets that indicate a level of progress needed across 3 key areas, sort of 3 significant places. 150 million fewer tobacco users, 150 million more people under hypertension management, and 150 million more people with access to mental care. They're not meant to be comprehensive, but they're meant to be really signifiers of what progress would look like. And you'll certainly hear it said that these targets could be more ambitious, like why not 500 million in each case? But the fact these targets have survived a tough negotiation progress is evidence, we think, that this declaration represents political commitment to faster action. And the 2 other targets that I would draw attention to are around access to NCD medicines and care, which is, as we were just hearing, one of the biggest bottlenecks in the NCD response and in achieving universal health coverage more widely. And the two targets there are at least 80% of primary healthcare facilities in all countries have availability of WHO recommended essential medicines and basic technology for NCDs and mental health at affordable prices by 2030. And the second is at least 60% of countries will have financial protection policies or measures in place that cover or limit the cost of essential services, diagnostic medicines, other products by 2030. And these two targets would be critical in delivering care while reducing the growing amount of out-of-pocket expenditure. And that results in meaningful change for people living with NCDs. And I just want to put that in context. Around 1.3 billion people have been pushed into or pushed further into poverty by out-of-pocket health spending. And considering that NCDs are around 2/3 of the health burden in most countries, and globally, we know that out-of-pocket spending for NCDs is estimated to be twice as high per visit to a health facility than for infectious diseases. We know that NCD care is driving household poverty and undermining economies. So that's why we think these targets are so important and why we commissioned David Watkins' new report. And we think it's going to be a really important tool in supporting their achievement. Moving on, while the headlines for the good news are mostly on the NCD care side, conversely, a large portion of the bad news on this political declaration are in the section on health promoting environments or disease prevention. And here, the commitments on delivering well-established evidence-based interventions have been diluted and weakened. And we think this is all showing the interests of health-harming industries who we know lobby governments so hard. Industries like tobacco, alcohol, ultra-processed food, and sugar-sweetened beverages, and indeed fossil fuels. And we've heard from early this year that representatives of these companies were seeking meetings with governments in their capitals and with their missions in New York. And it's very frustrating because these interactions are often not documented, and they're not transparent, but yet we can see these interests represented in the outcome of this negotiation process. And that's why we persisted in asking for every mention of the private sector to be qualified as relevant private sector, and for commitments to management of conflicts of interests in health policy making and delivery. To give one really big example for us is what's happened to commitments on fiscal measures. The originals published zero draft of this declaration, published in May, included a clear target of 80% of countries to implement or increase excise taxes on tobacco, alcohol, and sugar-sweetened beverages. This is totally removed from the final version of the declaration, and it's been replaced with a far weaker, more general commitment to implementing policies and measures to support health objectives, which will be really hard to trace and track as a target. This is totally removed from the final version, and in other paragraphs on health taxes, it does not refer to taxes on numerous health-harming products, such as sugar-sweetened beverages. It does mention tobacco and alcohol, but not sugar-sweetened beverages or foods high in salt, fat, and sugar. And we definitely see this as a missed opportunity to commit to other pro-health fiscal policies, such as subsidy reforms for health promotion. So as a result, we think governments are going to miss out on the triple win of health taxes. Because health taxes not only improve population health by reducing exposure to NCD risk factors, but they also reduce health systems burdens and costs. And of course, they generate much needed public revenue, which can be invested in health systems if governments so choose, which are desperately in need. I'd also say, as I mentioned, a great deal of weakening of language around other proven cost-effective measures to reduce the use of health-harming products. So, for example, existing commitments are watered down, like references to graphic health warnings and plain packaging for tobacco products have been omitted. Comprehensive bans on tobacco advertising have been diluted to just restrictions on advertising. Firm commitments to specific nutrition policies are now presented as a list of optional measures. Commitments to comprehensive packaging of to a comprehensive package of WHO recommended alcohol policies is absent, and the declaration does not address fossil fuels explicitly, and fossil fuels are the primary driver, of course, of climate change, but also of air pollution. So we see this sort of overall erosion of language that would have supported effective NCD prevention measures. And so I'm going to go back briefly now to finish on the good news. So governments have recognised the need for and committed to accelerated action on NCDs. And as you'll see elsewhere, not just in the Watkins report, but in other reports to be released ahead of the high-level meeting, we know that where governments take action, they get better results on speeding up the reduction on NCD mortality, and they get really good returns on their investment for their economies. So like we say, the declaration is now final. It'll get agreed at the high-level meeting, but we as civil society are going to continue to urge governments to take bold action to achieve these targets and commitments, but to go beyond them. We see this as a floor, not a ceiling. So we're really calling on governments to lead and create health promoting environments and make the necessary investment in NCD care, prioritising public health and well-being over those interests of health harming industries. And with that, I'm going to hand back to Katie. Thank you.
Thanks very much, Alison, for that big picture overview, as well as obviously the insights on the declaration and the upcoming high-level meeting. Let me just remind journalists, please pop in your questions into the chat box as we move forward, because we'll soon be coming to the Q&A section of the meeting. So now let me hand over to our final speaker. I'm very pleased to welcome our lived experience advocate, Nupur Lalvani, who is also a member of the Our Views, Our Voices Global Advisory Committee and founder of Diabetes Blue Circle India. Over to you, Nupur. Thank you.
Thank you, Katie, and thank you, David and Alison, for your reflections. It's a pleasure to be here at the launch of this really important report. We do know that countries are severely off track to achieving universal health coverage by 2030, and over half the world's population cannot afford to get the healthcare that they deserve, quality healthcare that people need. I live with type 1 diabetes. I've had type 1 diabetes since childhood. And the reality for a lot of us in low and middle income countries is that we pay out of pocket. We see the gaps every single day. And this is why I think what the panelists have been speaking about today is so crucial. And it's steps like these that really will make a difference for people living with various NCDs. Be it cancer or diabetes or mental health conditions. There are so many interesting facets to the report, and I read that there's a 30% chance of survival for a child that gets diagnosed with cancer in a low and middle income country versus 80% in a high income country. And these are really alarming statistics. These are not just numbers, these are actual people like me, like you, billions of us across the world. And I think there's something that needs to be done. All of our speakers referenced the need for political will. We're now, it's now time for the 4th high-level meeting on NCDs, and we really need to see where we are in terms of progress. How much progress have we made over the past several years? People often have to choose between food and tuition for school and medicines for people or for family members that live with chronic conditions. Another thing I wanted to pick up upon, and I know that came up a lot, was the prevention aspect. I think that's so crucial because really for somebody that has, for example, diabetes, like I do, uncontrolled diabetes or blood sugars over a prolonged period of time lead to definite and serious complications. And I know I see there are some friends from the press here that have covered stories, even from India, from our community, stories of people that have had type 2 diabetes, for example, for decades, and then had to go in for a kidney transplant. All of these complications are preventable. It's a lot cheaper for governments, for member states to, focus on prevention rather than, put in the money and effort for treating diabetes complications or complications related to NCDs. I think David also mentioned, some steps that governments can take. Also, the report mentions the WHO best buys. There's talk about pooled purchasing. Very recently, we've seen that the WHO has also added a whole list of drugs to the essential medicine list, which is, I think, wonderful news and a result of great advocacy by civil society organizations, by people with lived experience. I know this benefits my daily life and people that live with diabetes, because a lot of rapid-acting analog insulins have been added to the EML. So this is not just, it's not just talk, it's not just theory, it's something that impacts the lives of everyday people. I think also the focus on generic medicines is something that governments in low and middle income countries would find especially helpful to bring down the costs. I know there was a reference also to costs coming down up to 50%, with pooled procurement and using the other options that are mentioned. So I think the last thing I'd like to say is that, when there's political will and there's, when people come together, civil society, multilateral organizations, governments, academics, there's really a lot that can be done. And where you live or where you come from shouldn't determine how long you live or how healthy or how well you live. And everybody deserves a chance to live well and to live healthily and to thrive. And I think that's something that we're trying to do, through our civil society organization here at the NCD Alliance. I'll pause right here. Thank you.
Thanks a lot, Nupur, and thanks all speakers for those great remarks and insights. And as you can see, I mean, this report really does touch upon two critical issues for the high-level meeting. It's both about universal health coverage, increasing coverage of essential interventions and medicines at the primary healthcare level, and as well about increasing and making more efficient the levels of investment and financing going into this critical issue. So with that, we now move to the Q&A section of this briefing. As I've said previously, obviously, please feel free to add in your questions to the chat facility, and we'll get to as many as we can over the next 15 minutes or so. So let's begin with the questions that have come in. So the first question is from Jackie Thornton from The Lancet. A question to you, David. Great talk. Can you point to a country where they are paying higher for their medicines due to low volume, and any best practice examples of countries or regions getting together to negotiate better terms? Over to you.
Yeah, that's a great question. Thanks for that. So what's interesting is there aren't many published examples of country prices for medicines and this process of negotiating prices down. And many countries don't want to publish a lot of their data on medicines price they pay, because those are obviously confidential negotiations with industry. For our report, we looked at 4 countries where we were able to get access to those data. Unfortunately, I can't talk about those countries because those data were shared in confidence, but I will say that they run the whole gamut of countries, from very low income country in Africa to a relatively well-off upper middle income country in Latin America. And we find that prices of medicines are really quite idiosyncratic. There's no predictable relationship between national income and price of medicine, whereas you might expect. And what we did see in those countries is, and other sort of anecdotal evidence, is that countries that are smaller tend to also, if they're not working with larger countries, tend to pay higher prices for medicines. And countries where volumes are low because of low demand also tend to pay more. So the African country in our example that I mentioned, their proportion of people on hypertension treatment, according to surveys, is approximately 15%. So that means that 85% of people who have hypertension are not on any medicines at all. So if you think about the volume of medicines they're requesting, it's low because they don't have enough people who are accessing services and using medicines. And so, of course, volumes are going to be lower than they should be. So part of the solution here is also there's a bit of onus on the Ministry of Health to also expand access to screening and early treatment and get a better sense for need in the population and encourage utilization. in healthcare, we worry about increasing costs a lot. But actually, the problem for a lot of this basic NCD care is underspending and underutilization of care. And so part of the issue is countries also getting a better sense for how much they actually need to be spending, what volume of medicines they actually need to be procuring. And in doing so, you increase the quantity of medicines and reduce the price per dose of medicine procured. So you get better deals on the medicines you're buying. So there are a lot of examples of this for pooled procurement in general for medicines. For NCD specifically, I'll mention two examples. The Pan American Health Organization regional office has a strategic fund that's dedicated to supporting countries accessing NCD medicines. And there was a report from a few years ago that looked at the experience in reducing medicines for cardiovascular disease and primary care, reducing prices. So their pooled procurement initiative was able to reduce cardiovascular medicines in some countries by like 95 to 99%. Which is huge, and really signifies that working together and purchasing on volume can reduce prices for all and make everyone better off. Another example is in India, where there's a national cancer grid, and there was a report from a couple of years ago from folks at Tata Memorial Hospital that showed experience in negotiating cancer drug prices. And they found that pooled procurement across states in India, using the national cancer grid structure, reduced prices for medicines by about 80% on average. So you're paying basically 20% of what you would have been paying if you'd been purchasing as one state alone. And for some cancer drugs, the reduction was 90, 95%. So this is really, really powerful tool. It's not a panacea, but it's a really powerful tool because when you have underutilization of services and low volumes being procured because of low demand, you can at least band together to get better terms for purchasing, and then over time encourage industry to ramp up production to meet a growing need. Thanks.
Great, thanks, David. And while I'm with you, maybe just another kind of follow-up question that has just come in about the report to you specifically. It's from Ho Francisco from Signal TV Philippines, asking, is there any specific data that you can share about the Philippines from the report and your analysis?
So what I can share about Philippines, I'll just give another example. Philippines is another interesting case because it's a country that is really made a lot of progress on universal health coverage and expanding access to primary care, and a lot of progress on tobacco, a kind of counterexample to the stagnation we've seen that Allison was mentioning. But it's interesting because as a country, Philippines delivers health insurance to all and principal access to health services to all. But still, you have utilization of basic primary care services for NCDs that is quite low. So taking the hypertension example that I mentioned just a moment ago, I was just looking, and the Philippines is not as bad off as the other country I mentioned, but maybe two out of every three people with hypertension are not on treatment. And so you still have this massive gap, even in a country that's committed to universal coverage and is committed to financing the health system, big gaps in implementation. And that's, not all the government's fault. Sometimes it just takes time to build awareness in the community. But this is really where the financing solutions lie, is in generating population demand for more services and pressuring governments to spend more to deliver those basic services. So we think this message is relevant in countries at various levels of income, and there are efficiencies to be gained across the world, including in countries like Philippines. Thanks.
Great, thank you. Let's come to you, Alison, if that's okay. We've had a question from Jackie at the Lancet as well, regarding the dilution and weakening of the political declaration. NCD Alliance sent out a strongly worded release about this last month. How would you describe your response to what has happened? Is the dilution worse than what's happened in previous NCD high-level meetings, and are the industry techniques getting worse? Over to you.
Thanks. Thanks, Jackie. How would I describe my response? I mean, I guess we find it frustrating because there's sort of a lack of logic in it, and I'll talk a bit about that. First of all, many of these commitments that have been weakened or watered down are kind of pre-existing commitments and things that governments have supported, particularly through the World Health Assembly. And also, a couple of the ones I mentioned on tobacco come straight out of the Framework Convention on Tobacco Control. So governments have already supported and agreed many of these things. So you'd think it would be quite straightforward to maintain specific support and just be committing to action on them rather than trying to water down language. And particularly in the face of what's happening right now in terms of, as discussed already, the growing disease burden and the significant cost both to governments in terms of their health systems and to individuals and what that does to the economy. And yeah, those growing costs. So what happens with the health harming industries is they're very good at lobbying and saying that their products are good for the economy or they're providing employment and so on. But what they don't talk about is how they are externalizing the costs of their business on the rest of the economy. The health costs, the care costs, the women and children who have to stay at home looking after care rather than developing their own education or careers. And what that does to the economy. So that's frustrating the way, and they are very good at what they do, but they have been for a very long time. We've produced our Mythbuster document that we've circulated to governments from an early stage, and we'll continue to develop a news that really looks at this sort of playbook that many of the health harming industries are using. We associate them a lot with the tobacco industry, but they're being used by others like the alcohol and even sugary drinks industries, talking about, a lot of stuff about damage to the economy whilst not recognising the damage they're doing themselves. So yes, I would say it's there's a sort of illogic in it. Governments are desperate for revenue at the moment, and yet there's no commitment to the fiscal measures or and the triple win that brings. And they could be saving costs by delivering these prevention measures and the return on investment that would give to their economy. So yeah, it's frustrating to see this weakening and watering down, which is in the end in the interests of a handful of industries, not for household economies or the national economies and other companies within that who have to pay the price.
Thanks, Alison. I'm going to combine two of these questions because they're kind of covering a similar topic. I'll come to you, Nupur, first, and maybe bring David in as well on this one, because they're both around India. So question from Anuradha from the Indian Express. Access to medicines is the largest bottleneck according to the report. Any particular observations related to India? But also wrapping in this additional question from Lata Mishra. Given India's large pharmaceutical industry, why is access to affordable NCD medicines still such a challenge domestically? So let me pass that over to you, Nupur, first, if that's okay, and then I'll come to you, David, after. Thank you.
Sure. Thanks, Katie. I think that for people living with NCDs in India, most of us pay out of pocket, and that's a huge problem. And while there is a huge pharmaceutical industry, a lot of it, services countries abroad where we're developing biosimilars, for example, through some companies that are sold in Europe but not yet available in India. So I think there's a problem there with out-of-pocket costs and no universal health coverage. Also, some bottlenecks with having more generics and biosimilars, but maybe over to David, you're the expert there with. Thank you.
I would just add that I think that's absolutely right. I think my understanding, and I'm not an expert in India, by the way, but I think that my understanding of the situation is that also because so much of care is in the private sector, there's less pressure to, essentially ensure access to in public sector clinics at very low prices for individuals. And so, people may go to private pharmacies to buy medicines and there's a profit associated with that. And so I think the solution here is also kind of extending current health reforms and strengthening primary health care in the public system for individuals who can't, afford to receive private care. I think that's probably, in my sense, one of the bigger things. But I think this point about producing domestically and then exporting is a really important one as well. So the incentives are not quite aligned towards serving the domestic market.
Thanks a lot. So questions are coming in thick and fast. I'm going to try and get to all of them. Alison, I'm going to pass over to you two questions. One of them builds a little bit on what you was the response you just shared to the previous question about industry, particularly obviously health harming industry. So this is a question we've had from Isabel Choate at The Guardian. asking, are you aware of changes of tactics by lobbyists? And have you observed any patterns in terms of countries that they're targeting? For example, low-income countries that might just be getting started to look at fiscal measures. And let me bring in a second question to you, which is from Kerry Cullinan from Health Policy Watch. Which countries have pushed back for the removal of references to health taxes in the declaration? Over to you.
Great, thanks. So the challenge is government. There's no transparency in these meetings between governments and these industries, so we don't know when they happen, they don't get recorded, and we don't get transcripts of what they discuss. So it's really hard for us to see exactly how their tactics are evolving. But there are really standard arguments that we see coming through, particularly on fiscal measures. And like I say, we can share with you our myth buster on this. So, for example, one thing we saw over the last couple of months is a think tank came out with a report talking about how if you raise tax on tobacco, you'll end up with less revenue in the long term. So that's a standard argument they've been using for a long time against tobacco taxes, and they've wheeled out another report to try and show that during the, at a point when we're talking about trying to put taxes on health taxes. So that's a really standard thing that they would do. And this think tank has a history of funding from the tobacco industry. So that's sort of the typical thing that we see. And again, I talked about how they use economic arguments, and they talk about civil society being anti-business, and so on. In terms of, who do we, who's been lining up for and against, it's really hard, again, for us to say. We hear bits and pieces about how the negotiations have gone, but it has been a closed government negotiation. Again, we've not been allowed in the room, which, again, we would have liked to have been, but it's not possible. But we have heard bits and pieces about what goes on outside of the room. So, for example, we know in the European Union, for example, many governments there are against taxes on alcohol because they have a large wine industry, for example. And so we constantly hear pushback on those. And so that we can only make some assumptions about where some of this pushback has come from based on what we've heard elsewhere on other arguments about taxes. I think those were the two questions for me, Katie.
Thanks, Alison. Let me come back to you, David. I think this will probably be the last question unless anyone gets another final one into the chat. So we've had a question from Monica Mauni's Kayombo from Zambia. For a country like Zambia with a population of 18 million people, how much on average should the country spend towards NCD prevention and control? Over to you.
Thanks very much. I don't have the numbers for Zambia right on my in my computer right now. I can please follow up. I can send you those. But I think in general, for a country like Zambia, our report estimates that a country would need to spend around 1.5% of GDP on NCDs. And maybe that number would be closer to like 0.8% or so if the country were to achieve kind of global reference prices, like competitive, low prices on those generic medicines. This would be probably, I guess, around $10, $15 per person on NCDs. And this is assuming 80% population coverage. Now, again, utilization is currently low, so it's not like tomorrow you'd have to be spending all that money, maybe a third of that money or something like that. I think the government spends probably around $30 or $40 on health right now, if I'm not mistaken. So this would be a considerable share of the current budget. But as the country looks to expand health spending, NCDs would be a larger part of that. The other thing I would stress is that in our costing, we looked at the cost of achieving 80% population coverage or 80% of people accessing care right now. In many countries, it's not feasible to get there right now. They would start smaller and grow over time. And so, might spend $5, $6, $7 per capita or target that over the next few years and then gradually expand to something like $10 per capita on primary care NCD spending. And so the message here is we want to make sure that this is feasible to do because we've seen countries scale up NCD services and increase financing, but it doesn't happen overnight. And so if the target seems daunting, it's because it's meant to be a progressive target as resources become available. But that's approximately the magnitude of spending we'd be talking about.
Great, thank you. So yeah, progressive realization of the targets and of UHC and PHC. Great. I think that's all we've actually. Oh, sorry, I've just seen another question come in. Let's take one more and then we'll wrap up. We've got a question in from Ali Asif Shawan, and I think this is to anyone that would like to take it. What is your recommendation for Bangladesh to address the NCD challenges? Who'd like to take that one?
I could say a couple of things. I mean, my understanding is recently Bangladesh has come out with a sort of a new commitment on NCDs and a sort of multi-sectoral plan. And that's exactly the type of thing you need. You need all countries need to have a multi-sectoral plan because tackling NCDs isn't just about health. It involves, we're talking about the different prevention measures as well as investing in health systems. So you need a multi-sectoral plan, strong commitment and leadership from government to deliver. And as David's been saying, you need to make a commitment to investment. And we're talking about this sort of 1 to 1.5% of GDP type investment in NCDs. But it's not just NCDs, and I think that also comes across in his report. You need a commitment to investment in health as a whole and health systems. So I want to make that clear. I'm not sure if Nupur or David would want to add to that.
I would just add that all countries are on a journey towards improving quality of care. And in a country like Bangladesh, you have maybe 15, 20% of people receiving, essentially getting their blood pressure and diabetes and things like that under control. Many countries is not much better, so I'm not picking on Bangladesh, but I think, we're all learning how to do primary healthcare better. And I think innovations to improve the quality of service delivery, even in a country like Bangladesh, that's made a lot of progress on access to health services in recent years. And actually historically has been kind of a leader in the region. I think this journey of trying to innovate in primary care to deliver better high quality chronic care will be a priority. And also, again, as Alison mentioned, reducing risks, the multi-sectoral sorts of things, and that prevention piece is really important for ensuring the financial sustainability of the health system.
Yes, I agree. In addition to what Alison and David mentioned, I think focusing on health promotion and prevention really is the key for a lot of our, South Asian countries where a lot of the folks are predisposed to, diabetes or certain other conditions, type 2 diabetes. So I think that health promotion and prevention is also very crucial.
Great, thank you so much, all. I think that brings us to the close of our briefing. Thank you to all of our speakers, obviously David, Alison, and Nupur. Thank you to all the media that have joined us today. All the journalists will have received the report that we have obviously been talking about. You will also have received our press release that is embargoed until 3 p.m. UK time today. Obviously, Alison was referring to the political declaration. As soon as the declaration is formally published, we'll be sharing it with you all, as well as our NCD Alliance policy brief, which is our kind of formal response to the final declaration. And obviously, please keep checking on ncdalliance.org for additional materials and resources in the lead up to our Global Week for Action on NCDs that starts just over a week away on the 18th of September. Thanks again all for joining and have a good rest of your day. Thank you. Goodbye.